Yes. Welcome once again to Rad 211 class, Procedures 3. Okay, so we're talking about cardiac and circulatory pathologies. First off, the anatomy and physiology of the circulatory system. You got the heart, which is the main, like the central pump, and then going out from the heart there's arteries, as you know. The arteries feed into capillary beds. The capillary beds feed back into the veins, and then we return back to the heart. Two separate systems, pulmonary circulation and systemic circulation. Pulmonary sends deoxygenated blood back to the lungs to get refreshed, get rid of waste products, take on oxygen, and then come back to the heart and then be sent out into systemic circulation to give said oxygen to the muscles and organs and to bring their waste products back to be gotten rid of. All right, here goes a picture of the heart. This is actually not a bad heart picture. Okay, as you know, the heart is located behind the sternum, center of the chest. It's right in between the lungs. But the apex of the heart, the little, the tip of the heart that's inferior there, that's kind of kicked out towards the left. So a lot of times we think of the heart as being on the left side of the chest. I guess it kind of is, but it's mostly in the center. There's two chambers, the atria, the right and left atria. This is where blood enters the heart. I guess like an atrium or whatever, you know, an entryway. The ventricles. The ventricles are the parts of the heart that actually pump the blood, and then the layers of the heart. The endocardium is the inside lining. Think of that as like the tunica intima. And then there's the myocardium. That's the muscular part of the heart, the thick part, that actually does the work. And the muscles they're striated muscles, but they're in bands, and they kind of overlap one another. Almost like a bias ply on a tire when you think about it. And then the outer layer of the heart is the epicardium. Now the epicardium is in direct contact with the pericardium. We're going to take a look at that in just a minute. And blood travel, okay, into the right atrium and then into the right ventricle, through the right ventricle and the pulmonary valve up into the main pulmonary trunk. Then we're going to go out to the lungs, return back from the lungs by the pulmonary veins, which are now carrying richly oxygenated blood, and that's going to feed into the left atrium and then through the mitral valve down into the left ventricle, and then it's going to get a good hard squeeze and send it out under pressure into systemic circulation. Gas exchange happens at both ends. I showed you guys a slide about that in the last unit. Gas exchange happens in the lungs where carbon dioxide is ejected and oxygen gets taken in, but then gas exchange also happens in the capillary beds, you know, down in your fingers and toes and in all your organs. That's where the oxygen is going to be fed to the cells, and then the cells are going to give their carbon dioxide back to the bloodstream and send it back to the lungs to be released. Now then, here goes a picture of a normal heart, normal pericardium, and as you can see, okay, the pericardium is a double-walled sac. Okay, one wall is in contact with the heart, the other wall is in contact with the rib cage, you can think of. It's kind of like the visceral and parietal pleura. As a matter of fact, it's exactly like that. So the heart, when it beats, it has to move, and as you know, anything in the body that moves has to have some lubrication. So there is some fluid in that pericardium. It's supposed to be a thin layer, and it's supposed to grease the motion of the heart. Now the problem is if blood or serous fluid, if there's an infection and pus builds up inside the pericardium, then that can cause hydrostatic pressure to build up, and that's going to squeeze on the heart and prevent it from being able to expand and contract. And you know, always stuff like that is detrimental to our patient. This is why doctors have to, if a patient does have fluid buildup in the pericardium, they do what's called a pericardial centesis, and they get that fluid out of there, aspirate that fluid so that the heart can beat normally. Otherwise, the heart can go into tamponade, which is the inability to expand and contract, and that can be lethal for your patient. Okay, the cardiac cycle. I am the worst. Okay, I can put the leads on somebody and I can, produce one of these strips. But deuced if I know how to read this thing 100%. I've been looking at these strips for years and it's still kind of a mystery to me. I know, okay, the P wave is when the sinoatrial node kicks off an electrical impulse. It says, okay, it's time to beat now. And then the QRS complex is where, we have a contraction and then an expansion of the heart, which is known as systole and diastole. And I cannot remember for the life of me what that T wave does. That's like after the heart has beat, then the T wave like repolarizes the cells so that they're ready for the SA node to send them a fresh pulse. All right, I've got to go get my point clicker. This running back and forth to the computer is driving me crazy. Well, I'm back. Now I have my point clicker so that I can just kind of hang out over here next to the camera and y'all can hear my lovely voice and I can advance. Okay, so the arteries. Arteries and veins are constructed similarly. The arteries have a tunica adventitia, you remember from the last unit. That's the tough outer covering of the artery. And then the tunica media is the muscle layer that controls the diameter of the arteries. And then the intima and lumen. The intima is the inside lining, the endothelial layer, and the lumen is actually the hollow part of the pipe. That's where the blood and the plasma and blood cells flow through there, through the lumen. Veins have similar construction. Now, the difference between arteries and veins is the tunica media. With veins, the tunica media is much thinner. It can expand and contract. You might notice if you go to the gym and you're working out, especially if you're doing like aerobic exercise, and you'll notice that your veins start coming to the surface and expanding in size because the blood flow is higher. Now, but veins don't have the ability to really squeeze like arteries do because arteries are part of how your body maintains its blood pressure. So if, like, say for example, you get in a car crash and you get a really bad cut and you're starting to bleed and you're losing a lot of blood volume, then your body, your brain will send signals to the arteries to contract and also to the veins to kind of shrink down into the tissues in order to make the most of what blood supply you have left. The heart will try to feed itself and it'll try to feed the brain because those are really the two main things you need. I mean, obviously you need your liver and your pancreas, but you can live longer without a liver than you can without a brain or a heart. And then of course the capillaries are super, super small. Some of the capillaries are so small that there's just barely room for blood cells to pass through there. When we do chest radiography, one of the first things the radiologist is going to look for is the heart shadow. He wants to see if there's any signs of cardiomegaly, for example, or if there's any like a change in the position of the heart, and also the great vessels. You'll notice on radiologist reports they'll say, well, the heart and the great vessels are unremarkable. That just means they're where they're supposed to be and they're the size that they're supposed to be. And the great vessels consist of the IVC, the SVC, the aorta, and the pulmonary vessels, the pulmonary trunk and its subsequent branches. Now, if a doctor's looking at a chest x-ray, another thing he's looking for is vascular lung markings. That's blood vessels in the lungs. Got to be able to see those. If you use too much technique, a lot of times the lung tissue will be too dark and the doctor has to like window width and level. But if it's too dark, then sometimes he can't even do that. So that's why we're supposed to use the right technique for our chest x-rays. Now, if there's a pneumothorax in the chest, what it'll appear as is like an area that has air in it, but no lung markings. So that's a dead giveaway for pneumothorax. And pulmonary emphysema is like an expansion of the lungs. You guys remember from, I think, Unit 3, we were talking about emphysema The bony thorax. A lot of times if a patient has scoliosis, then the doctor will see that on a chest x-ray. And if a patient has pexus excavatum, that might be a little bit visible on a PA chest, but it's absolutely visible on a lateral chest x-ray. Now a little bit more about chest radiography. It's not really hard to penetrate the patient's chest. We can do that quite easily with fairly low technique. The reason we use a high kVp is so that we can get a nice even penetration, and so we can use a really short time. Because remember, the heart is always in motion. So we're basically doing stop motion radiography here. So we're going to use high kVp, high MA, and a very short time, like 3 or 4 milliseconds typically. You guys know how to position your patient. You're going to get them PA, shoulders rolled forward, all that good stuff. Geometric factors also include, like if your patient is lateral and they're leaning towards the bucky, that can actually cause foreshortening on the chest x-ray, and the doctors don't really like that. Patient factors include pathology. Do they have extra fluid in their lungs? Do they have extra air in their lungs? Are they just plain huge? You know, some of our patients are, you know, like 3 or 4 times bigger than me. And when we're doing our image critique, what are we looking for? Apices, angles, and we're looking for bones through the heart shadow. If we can see the vertebrae through the heart shadow, then we know we had a good technique. Otherwise, if we can't see bones through the heart shadow, that means we didn't penetrate it enough, and we probably need to go back and reshoot that, because when the doctor goes to window level that thing, it's just going to be a white blur out there that he can't do anything with. And as y'all know, this is one of the most commonly performed radiographic procedures unless you're at an orthopedic site. Here goes a chest x-ray. This looks like something I would have shot. You know, with clipping the angles off here. I'm really good at doing that. Okay, if you're looking at some of these CT scans or MRIs, you might notice, see right here, okay, that aorta is calcified and it's giant. So what's happened here is over time, a section of the patient's aorta has ballooned out. So this is an example of aortic aneurysm. And over here is another picture of an aortic aneurysm, this time on an MRI. And with MRI, the blood vessels show up really nice, even if we didn't use contrast. And here goes another MRI. This image over here, and this thing is kind of stretched out for some reason, but this image over here on the left is just a normal MRI scan. But if you look over here, you'll see right here where we've got blood in the pulmonary trunk, but then right here it's like there's an area where there's not any blood. MRI, like I said, you don't necessarily have to inject contrast into the patient to be able to see the blood vessels, and if there's anything inside the blood vessel, it'll show up. So this is almost certainly pulmonary embolism. Okay, angiography. As you know, blood vessels don't show up too well on an x-ray, but if we put contrast into the vessel, we'll be able to see it. Now, right here, you see how there's contrast in the vessel, but then all of a sudden it's just like it's blocked? Okay, well that's probably thrombosis, a blood clot in the blood vessel. With angiography, we can actually, if we tie tourniquets on the patient's legs and then inject contrast into their feet, then we can do something called venography. And that'll let us see if there's any DVTs in the patient. And this is before and after a declot procedure. And declot just means we're going to go in there and the doctor's either going to try to suction that clot out with a catheter, or sometimes they'll just try to grab it, you know, with like some forceps or something and drag it out of there. So if a clot's bad enough, there's nothing you can do. I mean, you just have to pull it out. And sometimes, like in the day, they used to do surgeries, like if somebody had atherosclerosis or blood clots, the doctor would actually perform a surgery. He would cut down to the blood vessel and open up the vessel and scrape the clot out of there and then stitch it all back up. Using a catheter is much easier on the patient. Therapeutic angiography typically consists of percutaneous transluminal angioplasty. This means that we're going to go in there and fill up a balloon with water, typically a combination of water and contrast so we can see what we're doing. And once the doctor has opened up the vessel with that balloon, then a lot of times they'll just go ahead and put a stent in there, to keep the vessel from collapsing back down. We can also do thrombolysis, which is breaking up a blood clot, and we have some specialized equipment that does that. I'll show it to you in crud. I think it's, one of the units we've got coming up where we're going to look at some specialty equipment. And then embolization. If a patient's bleeding, like say they've got a GI bleed or something, it's possible for the doctor to go in there and find the artery that's feeding that area and put down like some embolic foam or those embolic spheres. They can also do embolization with like a strong chemical solution like alcohol. Alcohol basically burns the inside of the vessel and causes it to close up. It works. TIPS procedure we talked about in the last unit. That's where the doctor is going to go in and rig a bypass for the liver to relieve portal hypertension. I'm not sure why I have angioplasty in here twice. I need to fix that. I've been doing some work on this PowerPoint, so I'm going to upload the new version for you guys. And then sometimes the doctor needs to put in a catheter, like a portacath or a perm cath, and that's going to reside in like the subclavian veins. And here goes an example of an angioplasty balloon. What the doctor's done is fished this thing up into a blood vessel, and this thing is really magnified. Okay, so it wouldn't be like this huge. But this is up into a vessel, and then the doctor pushes like a combination of water and contrast, which forces that balloon to open up and can stretch open the blood vessel. And this kind of plasty can be done in a lot of different vessels. Sometimes they'll do it during an ERCP. I've actually seen doctors stretch open a patient's esophagus using a giant balloon and then put a stent in the patient's esophagus. Kind of neat looking. Interesting stuff. Okay, in the fetal circulatory system, we talked about this some yesterday. You've got the foramen ovale, which is between the right and left atria, and the ductus arteriosus, which is up at the top. It's between the pulmonary trunk and the aorta. Okay, that's how the fetal circulatory system is supposed to work. Now, each year, about 1% of live births in the United States, the baby is born. Now there's more than this, babies that are born with some kind of a birth defect, but CHD, that stands for congenital heart disease. I was about to say congenital hereditary disease, but I was like, no, that's not right. Congenital heart disease is what CHD is. Now, why do people get born with a heart defect? We don't know. It just happens sometimes. There's a lot of different theories. Some doctors say it's because if the mother was exposed to chemicals, or if she drank or smoked. Could just be because it might just run in the family. That totally happens. Genetic disorders. Associated complications typically take the form of a heart murmur. The doctor, when he listens to the patient's chest, which is called auscultation, he can hear that there's something not right in there. And it could be a foramen ovale, or it could be a valvular defect, or it could be something else. We don't 100% know. We know something's wrong. And then the doctor can also rig up an EKG. We can do echocardiography, chest x-ray, CT scan, MRI. There's a lot of different ways we have of finding out what's going on in somebody's heart without actually breaking out the knife set. Okay, patent ductus arteriosus. This accounts for 5 to 10% of these congenital heart defects. It's more common in premature infants by far. And if you think about it, it totally makes sense, because premature infants, their body is basically still designed to be inside the womb. They're not supposed to be out yet, but they are. So then we have to take care of them as best we can. Treatment is typically by surgery, although it is possible to go in and perform interventions, like basically plug it up using specials, like putting a catheter up into the patient's aorta. And prognosis is generally good. If this thing gets found, the doctors can fix it. You know, if worse comes to worse, they can do surgery and just close that thing up. You know, put like a, basically just like a stitch around it and close it down. And here is a PDA on a radiograph. This is with a contrast. You can see here the catheter is up into the aorta, and then the doctor has pushed a big bunch of contrast. This is a flush study, and as you can see, there's a connection right here between the aorta and the pulmonary trunk. That shouldn't ought to be there. Now on a CT scan with reconstructions, it's a little bit more obvious. This is probably not the same patient. This is a little PDA right here. But there it is. A connection that shouldn't ought to be there. Now, coarctation of the aorta. This is, this could be evidenced in a really small infant, but usually this doesn't crop up until a little bit later. You know, people notice it as the patient starts to grow, but a section of their aorta does not. This is a cartoon version. This is the real deal. If you look, you'll see that there's an area here that's narrower than it should be. And see how irregular these vessels are? That's how it is in the human body. Your body never does look exactly like the pictures say it's supposed to. This coarctation generally is found because, you know, like the kid gets out of breath easily, or they have like an elevated blood pressure in the left side of their heart. You know, but once we found this thing, the doctors can go in there and fix it surgically. A lot of times this is something that's, you can't just balloon it open. It has to actually, the doctor would have to maybe cut this section out and then stitch, you know, basically do like a aortic resection. And this is just that same picture again. Okay, septal defects. Atrial septal defects, fairly common. A lot of people are born, they say they've got a hole in their heart. Well, kind of. There's a hole between the right and the left atrium. There is going to be mixing of oxygenated and deoxygenated blood. So if that hole is small, then it might not cause a big issue. But if the hole is large enough, then it's going to cause deoxygenation of the blood going out to your muscles, and you're going to get tired really fast. Ventricular septal defect, kind of the same thing, but except for it's between the right and the left ventricles. And since the pressure there is higher, it's a bigger problem, because when the left ventricle squeezes, it's going to, you know, instead of putting its blood out through the aorta, a lot of it's going to go back into pulmonary circulation. Now, why do people have these septal defects? We don't know. Doctors have never, I mean, there's some theories out there, but doctors haven't ever figured out like something that's the cause. Could show up on an EKG, or I'm sorry, an ECG, can cause a heart murmur. It almost certainly does. And if this thing is left untreated, a septal defect can wind up causing cardiomegaly, not cardiomegaly, and also pulmonary vessel changes. You know, the vessels might appear larger than they normally would be. Complications, like I was saying, the patient gives out of breath easily. You know, they might actually be cyanotic sometimes. And treatment is either surgery, or the doctors can go in and deploy a device called the Amplatzer, which I'm going to show you in just a minute. And basically what it is a plug that goes over this hole. So if you look right here, see that hole there? That's an atrial septal defect. And see that gigantic hole right there? That's a ventricular septal defect. Now, the septum down here between the ventricles is really thick and strong. It's pretty uncommon for there to be a septal defect there. Now, here's that device I was telling you about. Okay, if there's a hole in the heart, then what the doctor can do is come in here, see, here comes our catheter, and we've got this Amplatzer device, and the doctor's deployed part of it, and then he's just going to pull it back against the wall here, and then deploy the second part. And so what this thing acts like is a tire plug, basically. We're just going to put this plug here over that hole, and with any luck whatsoever, the flesh of the inside of the heart, the endometrium, is going to kind of grow over this thing, and it'll just become part of the patient's heart. And it's flexible, you know, so as you know, the heart's in motion all the time. This thing will bend and flex with it, you know, so it should form a very efficient plug. And this device was invented in Europe, Germany, I think, and I believe that it now has FDA approval, so it can be used here in the United States also. Okay, a little bit more congenital and hereditary stuff. Transposition of the great vessels. Now, out of all, you know how I told you guys that there was only like 1% of babies that were born with cardiac anomalies? Out of that 1%, 5% of those have this deal. The right ventricle is hooked up to the aorta, and the left ventricle is hooked up to the pulmonary trunk. And you might think, well, you know, what's the big deal there? They can just trade out. No, it doesn't work like that. In this case, there's no mixing of oxygenated and deoxygenated blood. In other words, the pulmonary circulation is just going around and around in a circle, and so is the systemic circulation, and the baby's not getting any oxygenation. This is something that has to be corrected like right this minute. Otherwise, that patient's not going to last. And right here goes like a little diagram of how this thing works. So the aorta is connected up to the right ventricle, and the pulmonary trunk is connected up to the left ventricle. And if we inject some contrast into the patient's inferior vena cava, look at how it goes up through here. It goes into the heart, and then it goes out the aorta and right back into circulation. We're not going to the lungs at all. So, you know, this patient only has minutes to live after the umbilical cord is cut. As long as this baby is connected up to its mom via the umbilical cord, it's got no problem because the mom is providing the oxygenation for it. But as soon as we cut the umbilical cord, yeah, we're going to have a big issue. Now, here's that tetralogy of phallic again. I want you to remember this because you will see it again. It's a combination of 4 defects. We got pulmonary stenosis, so we got like a really, really skinny entry into the pulmonary circulation. We got what's called an overriding aorta. See how the aorta is sitting like in between the right and the left ventricle? So it's getting blood from both places. And then we've got a ventricular septal defect. There's a big hole right here between the right and left ventricles. And because the heart is working overtime to try to supply the body, the right ventricle is hypertrophied. It's way thicker than it normally would be. On a radiograph, sometimes this, you remember that thing that we looked at on, I think it was on our Kahoot, and it was called the cour en sabot. That's French for foot in shoe. Sometimes on a chest radiograph, the heart will be shaped kind of like a boot, and that is like very suspicious for tetralogy of phallic. Okay, now valvular disease. If your valves of your heart get damaged, and typically it's like the aortic semilunar valve and the mitral valve, those seem to be the ones that are most popular to get damaged. You can have all kinds of problems. Dyspnea, you know, painful or troubled breathing, easily fatigued, syncope, you know, people that have valvular disease because their blood is not going in one direction like it's supposed to be, so their heart's efficiency is way reduced. Their muscles and their brain aren't getting as much nutrition as they need, and so the patient just passes out spontaneously. And this can also result in a lot of chest pain, angina. Now, valvular disease, a lot of times this is diagnosed, well, the patient knows something's up. You know, they don't feel good, they don't have any energy. You know, if they try to walk up a set of stairs, they're just give out, you know, like halfway up the stairs. So then we go and do some exploration to find out what's going on here. Non-invasive, echocardiography, ECG, we can do that kind of stuff, and that doesn't actually involve us penetrating into the patient. Now, if we still don't have any satisfaction, what we can do is angiography. We can go into the heart with a catheter and flush some contrast in there, and then we can see exactly how that valve, is or is not functioning. Now, why do people get diseases? Well, there's several different things. Rheumatic fever is what you get if you have strep. Like say you had strep throat and you stubbornly refused to go to the doctor, so you didn't get any antibiotics. If strep is left unchecked, it can migrate into the heart and wind up damaging your valves. There's other diseases that can do that too. Okay, now valvular stenosis. Sometimes people are, and this could be congenital, some people are just born with really small valves or with valves that are dysfunctional. They just don't open and close like they're supposed to. It's also possible for the chorda tendineae to get damaged in the left side of the heart and cause mitral valve prolapse. In other words, those flap valves are just kind of flapping back and forth as the heart beats, and they're not controlling the flow of blood. And again, diagnosis typically is done by echocardiography. Can be radiography, provided we have contrast on board. CT scan, MRI, a lot of different things can show this up. Sometimes valve disease, because the heart is losing efficiency and it's pumping, but it's just not really getting anywhere because its one-way valves are jacked up. So the heart starts working overtime, and anytime the heart starts working harder than it normally should, you can wind up with cardiomegaly. Now what can we do here? Heart surgery, angioplasty, which would be putting a large balloon in to stretch that valve open. That might actually work. If worse comes to worse, we can put artificial valves in the patient. They can either be like stainless steel and silicone, or they can be what's called a porcine valve, and that is a heart valve that came out of a pig. I guess you could cop a heart valve out of a patient, like another human being, provided they left their heart to, if they left their body to organ donation. But most of the time they use port valves or these ball and cage valves. Now, as you can see from this picture, okay, what they've done, somebody's gone in and cracked this patient's chest and put these valves in. Looks like they've got a tricuspid and a bicuspid artificial valve. And you can't see it, but there's like a little ball that sits in here. It's made out of silicone, and that ball goes back and forth. Okay, so this is called a ball cage valve for obvious reasons. So the stainless steel cage is going to hold the ball from being able to really go anywhere, but it'll let the blood flow only in one direction. One direction. Now, congestive heart failure, we talked about yesterday at length. Left-sided CHF typically is caused by hypertension, could also be caused by valvular defect or disease, could be caused by coronary artery disease. Symptoms are typically fluid buildup in the lungs. The patient's rattling when they breathe. They're constantly having to cough up a lot of phlegm. And on a radiograph, you're going to see on a chest x-ray a lot of consolidation inside the patient's chest. Now, right-sided CHF, slightly different. This is typically caused by COPD, pulmonary hypertension, again, valvular disease in the heart. And right-sided CHF is going to be a little bit different. In this case, the left side of the heart is able to pump no problem, but the right side is not able to keep up. So the left side is pumping blood out into the extremities, but then whenever the blood tries to come back to the heart, the right side can't take it back as fast as it's being pumped out. So, you can kind of do the math. Like, okay, well, if I'm pumping a lot of fluid down to my feet and it's having a hard time getting back up to my heart, well, where's that fluid going to go? Out into your tissues. So you're going to wind up with gigantic elephant-looking ankles and feet. And y'all have seen people like that at the hospital. You pull those sheets back and their foot is just like huge. And I've actually seen people with their skin splitting because there was so much fluid pressure in their lower extremities. And it has to go somewhere. Excuse me. Okay, congestive heart failure typically shows up like this. Big old cardiomegaly. And it's very typical for people to have right and left side failure simultaneously. So their lungs and their body aren't getting enough blood. not enough blood flow. But look at all this consolidation in the lungs. Okay, that's a lot of fluid. Okay, cor pulmonale is caused by increased pulmonary pressure. You can have pulmonary hypertension just like you can have systemic hypertension. And if it's an acute case of increased pulmonary pressure, most of the time that's involving a pulmonary embolism. So a blood clot has gotten loose in the body and it's wound up getting in the lungs and it's plugged a major vessel, and all of a sudden the right-sided pressure just spikes. Okay, but then there can also be chronic cor pulmonale, and this is typically caused by COPD, chronic bronchitis, or emphysema, and also from people having long-term heart failure, congestive heart failure. So, you know, the pulmonary pressure gets really, really high, and the symptoms include dyspnea, trouble breathing. Patient might be prone to pass out because they're just not pumping oxygenated blood through the lungs like they're supposed to. Now, how can we find cor pulmonale? Well, on a chest x-ray, we might see like a really expanded right ventricle because of the increased pressure over there. Now, on a MUGA scan, I don't know if you guys know what this is. I can't remember what MUGA stands for, but basically, it's a functional study of the heart where we can see how much fluid the heart's taking in, blood, and how much it's pumping out. So there's like a series of pictures that then the doctor can look at, and they can do some measurements and some calculations, and they can figure out the ejection fraction of the heart, the right side and the left side, and see if those are comparable. And they should be the same thing. If they're way off, then there's an issue. And then of course we can do echocardiography. Ultrasound is getting really, really good at cardiac imaging. A little bit of degenerative disease, and then I'm going to have to take a little break because it's almost time for class. I've got the juniors coming in here in just like 15 minutes. Atherosclerosis. This is the most prevalent disease in humans. Just about everybody that's over age 50 has got some fat deposition inside their blood vessels. And as a matter of fact, in the United States, it's epidemic. And I guess that's because A, we live long, and B, we're eating potato chips the whole time, you know, so we're just cruising for it. Incidence is very high. I can't remember what percentage of the population has some kind of atherosclerosis, but I'm trying to say like 60% or something ridiculous like that. It's a bunch. Now, here's something that you need to know. Because of the increased pressure and the flexing constantly of the blood vessels, atherosclerosis, fat deposits, tend to accumulate in the aorta, in the coronary arteries, and, dun dun dun, in the cerebral arteries. So if you have a big plaque buildup inside your brain, then you are definitely at risk for a stroke. So, I don't know, try to eat right and exercise. Now, there are some risk factors. Controlled risk factors. Now these, the reason why they're called controlled, like in my case, totally out of control. I've got a bad diet and no exercise. Thank goodness I gave up smoking many, many years ago. So controlled factors are things that I could change if I wanted to. I could stop smoking, I could go on a decent diet, and I could get up and walk around the block every once in a while, you know, do a little bit of exercise. Now, risk factors that are considered as uncontrolled, in other words, there's nothing you can do about these, is old age. You know, as you get older, you're going to have more atherosclerotic buildup. And then, of course, family history. Some people are just genetically prone to buildup of cholesterol. And then some people aren't. You know, it's like, daggone, they can go through life eating a pork sandwich every day and never have an issue. Okay, these atheroma formations, these are basically like little plaques that build up in the body, and normally they're not visible on an x-ray unless there's also calcium deposition, because most of the time these atheromas are made out of cholesterol, and as y'all remember, cholesterol doesn't show up on an x-ray. All right, got some students hanging outside the door, and I've got to let them in, so we'll just have to pause this for the time being and get back to it in a few. junior students have finished their test. They're out the door. So now I can finish what I was talking about. Okay, here's a typical blood vessel. You know, just actually not a bad drawing at all. Normal artery. Okay, see how this lumen is nice and open, so blood can pass through there no problem. But if we have a lot of deposition of cholesterol, then that vessel can wind up getting blocked up, basically just like pouring grease down a drain. You know, that's the reason why you don't pour grease down the kitchen sink. You don't want that stuff to form a blockage in there, and then somebody's going to have to come in and roto-rooter that thing. And we can actually do that to blood vessels too. There are some devices like the rotoblader that can, the doctor can actually put into an artery, and this thing spins at like super high speed, and it'll break up those plaques, and it breaks them into such small chunks that they can just, you know, go back into the bloodstream. And then there's other systems that actually use like hydraulic pressure to like break up those plaques and suction them out. So that's kind of cool. We'll take a look at some different technologies for doing this kind of stuff. Anyways, atherosclerosis. Some people think that the reason why these plaques form is because of repeated injury to the endothelium. Then other people think, okay, well, it's just plain old deposition of cholesterol. Either way, if you have this kind of blockage, it's going to result in ischemia. Whatever's downstream from this is never going to get as much blood as it needs. And so what's going to wind up happening is, if somebody's got a blockage in their heart, then whenever they exert themselves, they're going to feel pain because their heart's not getting as much nutrition as it needs, and so it's going to send pain signals. And same kind of deal with the brain. If somebody's got like a partial blockage, sometimes they'll have what's called a TIA, which is a transient ischemic attack. Some people call it a mini stroke. But if this thing gets bad enough, and especially if a blood clot gets jammed up in there, then that can cause either a heart attack or it can cause a cerebrovascular accident. That's the CVA, also known as a stroke. Okay, coronary artery disease is caused by these plaque formations. It definitely can result in an infarction and wind up killing the patient. Some people have an infarction of like the posterior, the right main coronary artery, and that's referred to as the widowmaker because that's pretty much instant death. A lot of times people that start having a heart attack, you know, it starts out with ischemia first before the blood gets completely cut off, and they have serious chest pain, and then they come into Medac talking about, hey, you know, I've got a pain in the chest. And then we have to, a lot of times we'll do an EKG, you know, just to see what's going on, but a lot of times we just call 911 because if you're having a heart attack, you need to go to the hospital, you know, not to the emergency clinic. And coronary artery disease is and has been for a long time the single most common cause of death in men and women in the United States. Excuse me. And as a matter of fact, ischemic heart disease is the leading cause of death worldwide. Now, risk factors. Okay, if you're a smoker, and by the way, somebody was asking me, what does smoking have to do with coronary artery disease? You know, I mean, I can see where it would cause lung cancer, but why problems with the blood vessels? Okay, well, those LDL, those low density lipids that get into your blood vessels and cause these plaques, when you smoke, it actually helps the LDLs get into your vessel walls easier. So it like accelerates the deposition of these plaques. And of course, if you're eating a way high fat diet, you know, if you're eating too much cholesterol, then it's got to go somewhere. So, you know, the body just like puts it all over the place. It can wind up in your gallbladder. It can wind up in your blood vessels. And of course, if you're in poor physical shape, then that increases your possibility for getting coronary artery disease. Now, diagnosis. A lot of times diagnosis is via EKG. That's going to be definitive. And then treatment. If somebody has coronary artery disease, the doctor can go in there and they can do a bypass. They can do angioplasty and place a stent. There's a lot of different things doc can do. They can also do what's called an atherectomy, which means they go in there and cut that plaque away from the vessel wall and pull it out. Just get rid of it. Okay, myocardial infarction is a major league issue. This is an acute blockage of a coronary artery. In other words, you were fine just like 5 minutes ago, and all of a sudden, you know, like a blood clot or a piece of plaque or something breaks loose and jams up a coronary artery, and now a section of your heart doesn't have any oxygen, and it's going to object. You're going to have a problem. If that area of the heart is big enough, then it can just be like an instant death killer. Signs and symptoms, typically pain in the chest, you know, like crushing chest pain, radiating pain up the neck, radiating pain down the arm, typically the left arm. If you have any of those kind of symptoms, you know, please don't hesitate. Call 911. If you try to drive yourself to the hospital, you're liable to have a problem. You know, wonder if you get like halfway to the hospital and you have the big one, and then you go out of the road, you know, and winds up getting in a car crash and having a heart attack. That wouldn't be good. Early medical intervention, way important. Whenever I was riding with the ambulance service, they do what they call scoop and run. If somebody's having, like if they think it's a bona fide myocardial infarction, they don't spend a whole lot of time on the ground, you know, trying to mess around with the patient's heart. They just go ahead and throw them in the ambulance and haul butt for the hospital, because the faster you get to help, the better. And the person can go to specials, they can go to the operating room. Once they're in the hospital, then there's a lot of different things that can happen that can save their life. But if they're just laying out in a ditch somewhere, then, you know, none of that's going to be possible. Treatment, typically thrombolytic therapy, which means TPA, for example, streptokinase, urokinase. These are clot-busting drugs that can, basically, if they can get to the clot in time, they can dissolve it and restore the flow of blood. We can also do the old percutaneous transluminal angioplasty and balloon that vessel open and try to restore circulation that way. If worse comes to worse, open heart surgery is a possibility. And what the doctor can do is just right quickly go down to the leg and find a vein and take that vein out and use it to run a bypass across the surface of the heart. Okay, aneurysms. An aneurysm is just a weak spot in a blood vessel where it's starting to balloon out. And this can be caused by trauma, could be caused by infection, and some people are just genetically predisposed to develop aneurysms. The other thing is Marfan syndrome. Marfan syndrome is a connective tissue disorder, and people that have that are very prone to aneurysms. Now, there's several different classifications of aneurysms depending on what the shape of the thing is. A saccular aneurysm sometimes is referred to as a Berry aneurysm. These happen in the cerebral arteries very often. They're pretty common, and they treat them back in specials all the time using like embolic coils. Now, a fusiform aneurysm, typically that's going to affect your abdominal aorta, which the abdominal aorta is the most popular place to have aneurysms. And there's also such thing as a dissecting aneurysm. In a dissecting aneurysm, the intima has been damaged, and so blood is starting to flow like between the intima and the tunica media. And basically, if this doesn't get fixed, then it's just going to keep ripping because, you know, the pressure in your aorta is very high. And this is just like a little picture of how these things work. Now, the fusiform, also called a circumferential aneurysm, this is just where the whole vessel is just ballooned out. And this might not necessarily be an issue. Some people have an aneurysm and they don't even know it. But if that aneurysm gets to be more than 6 centimeters in diameter, then the doctors are going to want to operate on that, because that's a dangerous situation. In other words, if the ballooning is too much, then it's going to start stretching the walls of the aorta really, really thin. And if that thing breaks, then the patient can internally bleed to death in under 3 minutes. It can be very quick. There was a guy that I knew back in Silva, and he had an abdominal aneurysm and did not know it. And he was out doing some yard work, and the neighbors called 911 because, at first they thought he was laying in the yard taking a nap, no lie. But then they came back and he was still laying there, and so they went over to see if he was okay, and he was already cold. And he had had an aneurysm that broke, and they said it just killed him instantly. He probably never even felt it. Anyways, the saccular aneurysm is where just one side of the vessel is bulging out, and this thing can actually balloon out and get really huge, and that's referred to as a berry aneurysm. Now, a false aneurysm is something like this. We might do a CT scan on a patient and see, oh, it looks like their aorta is huge, right? But in reality, there's a damaged place here where blood has leaked out and formed a clot. And sometimes that can resemble an aneurysm, even though it's definitely not one. The other thing is the dissecting aneurysm. And this is kind of how that thing looks. What's happened here is something has happened and the intima has been damaged, and now the blood is able to flow out here. And what's going to wind up happening is, as this blood creates more and more pressure, it's going to cause the intima to peel away from the media, and that can wind up causing all kinds of problems for the patient. And abdominal aortic aneurysm, here's an example of one. As you can see, the catheter's going in here. It's going into the femoral artery and then up through the iliac artery and into the IVC. And then the doctor has pushed some contrast, and so we see the contrast going down these blood vessels, but we also see this big old aneurysm. Now what the doc can do is they can go in and put a sleeve inside the blood vessel, and that sleeve will take the pressure and hopefully prevent the aneurysm from actually bursting. And there are some companies that if you take make a CT scan of the patient's blood vessels, and then you send that CT scan off to the company, they will make a custom sleeve that fits into this aneurysm exactly. It's kind of expensive, but well worth it if you have a big aneurysm and you don't want to die. Okay, thoracic aortic aneurysms are not as popular as the abdominals. You don't see them all that often. Typically, they're either congenital, somebody is born with a weakness in the aorta, or they've been hitting the chest really hard, and that's caused an aneurysm. A lot of times these are visible on a chest x-ray, just because the doctor's looking at the great vessels, and if he's looking at the aorta, then he can probably see where it's expanded out. So it might be visible on a chest x-ray, but it'll definitely show up on a CT scan or an MRI or a cardiac ultrasound. Treatment: if it's bigger than 6 centimeters, then it needs to be surgically repaired or possibly sleeved. It would depend. The doctor would have to look and make that determination. I'd rather have the sleeve than the surgery, given a choice. And here's an example. This is an aortic aneurysm. You can tell because, see, we're above the diaphragm, right? So we're in the thoracic aorta. And so you can see there's a split in the intima somewhere in here. And you can see where there's a layer of flesh, which would be the tunica intima, and then there's blood back behind that. This is an MRI scan. So on an MRI, we don't need contrast. We can see the soft tissues very clearly without it. There are some occasions when you'll have aneurysms in the extremities. Most of the time these occur in the legs. I guess because of gravity, pulling the blood down, increased pressure in the legs. And a lot of times people that have an AAA, if they have a AAA, an abdominal aneurysm, then they're more susceptible to having these aneurysms in the lower limbs. Typically the popliteal arteries, a lot of times these things are bilateral, and the patient you may actually be able to feel the aneurysm back in behind the patient's knees. And usually these things are diagnosed, somebody will have pain. And they're like, what the heck, it hurts all the time and I can feel a pulse back there. These aneurysms are pretty close to the surface typically, and so Doppler ultrasound can show these things. We could see them on an x-ray too if we had contrast on board. Venous thrombosis, a lot of times people that are laying in bed for a long period of time, people that sit down at a desk for long periods of time, people that fly for a living, you know, they're traveling salesmen or whatever, they tend to be more susceptible to having a venous thrombosis. Incidence pretty high. I mean, this happens pretty often. People have a DVT, and the doctors go in and put a filter in the inferior vena cava if they're worried that a patient might start throwing clots, and that filter will hopefully catch any clots before they have a chance to get up to the heart. So a lot of times in the operating room and in specials, we'll go in on cases where they're putting in IVC filters. It's kind of interesting to watch, I think. Phlebitis is an inflammation of a vein. Thrombus is the formation of a blood clot. And thrombophlebitis is where somebody's got inflamed blood vessels and blood clots simultaneously. Diagnosis for venous thrombosis. Once upon a time, we used to do venography in the department. We would bring people in and tie tourniquets on their legs in order to force the blood through the deep veins, and then inject contrast into their feet and just watch where it flowed, you know. And you can see where it flows and where it doesn't. And where it doesn't flow, that might be a blood clot. Nowadays, we have really good Doppler ultrasound, and so venography is kind of a dead technology. I've got a presentation on it. I think it's on my YouTube channel. I can't 100% remember. Anyways, I used to teach it in this class because whenever I was a student, we did venography in the main department at New Hanover, but that's since gone by the wayside. Treatment typically is going to be with clot-busting drugs, or if the if the thrombus is too big, then the doctor's going to just have to pull it out of there. They got no choice. And there are some interesting pictures. If you go online and look for like thrombectomy, then there's some good pictures of blood clots that have been pulled out. I was in the OR one day and they were doing a declot on a patient, and the doctor pulled a clot out. That thing must have been 18 inches long. It was huge. Okay, so venous thrombosis might show up on a venogram, which this is. And here, if you look closely at this picture, this is an IVC filter. You see it's got like a radiopaque marker right up here at the top, and this thing has got like little hooks in it, and so when the doctor deploys it, those hooks dig into the wall of the inferior vena cava and hold it in place so it can't drift around in there. And then if there's any clots down low and they're heading back up towards the heart, hopefully they'll get caught in this mesh and not get into the patient's lungs or brain. Okay, a little summary of pathology. Okay, these are all additive pathologies. Coarctation of the aorta, that can cause like congestion in the mediastinum, and so that's considered as additive. Septal defects, those tend to be additive. Tetralogy of Fallet, basically anything that's causing a backup of the blood flow and additional fluid to be in the chest cavity is going to wind up being additive. Valvular disease, congestive heart disease, obviously, Pulmonale, and that's it. There's no subtractive pathologies that are associated with the heart. Everything, all the pathologies we've talked about, they're either additive or they don't really do anything, you know, as far as inhibiting us from penetrating the heart with x-rays. All right, excellent. Thank you very much for your kind attention, as always, and be sure to tune in once again when we do more fascinating pathology stuff.